Okay, let's get into this. Today we're doing a deep dive into, well, a condition in dogs and cats that sounds a bit strange at first, pelvic bladder.
Yeah, it's not your typical bladder infection or stone problem we often talk about.
Right, this is really about the anatomy, like specifically where the bladder neck ends up sitting. Apparently it's further back than normal, actually inside the bony structure of the pelvis.
Exactly. And what's really interesting and what we'll explore using the veterinary sources is how that specific anatomical setup, the structure, directly links to a really common clinical issue, urinary incontinence.
Okay, so our mission today is to pull out the key information from these sources. We want you to understand what a pelvic bladder actually is, what signs you might see, how vets diagnose it, and importantly, what can be done about it.
It's all about connecting that slightly unusual anatomy to the problem of leaking and why that location matters so much.
So let's start there. What exactly defines a pelvic bladder? You hear intrapelvic bladder too, right?
Yeah. Yes, intrapelvic bladder neck, specifically. It means the neck of the bladder, where it joins the urethra, is positioned caudal, that's towards the tail relative to the pubic bone.
Caudal to the pubic bone.
Okay.
So it's not riding higher up in the abdomen like you'd maybe picture.
Precisely. And because it sits back there, a fair amount of the bladder itself and, crucially, a good portion of the urethra end up staying within the confines of that bony pelvis
Uh-huh.
and this deep pelvic location. It's really strongly linked with these animals having a shorter urethra overall.
Oh.
And that combination, the deep position and the shorter tube, often leads to a functional problem. It's called urethral sphincter mechanism incompetence, or USMI. Basically, the sphincter doesn't work as well.
Got it. So structurally, bladder neck and urethra are deep in the pelvis. Urethra is often short, leads to function issues like USMI.
Yeah.
So who gets this? Is it dogs, cats, both?
Well, the sources we're looking at say it primarily affects dogs. It seems pretty rare in cats.
Okay, mostly dogs. Any specific type?
Yeah, it's most commonly diagnosed in young female dogs, often less than a year old.
Young females. Interesting.
And here's something else the sources point out. If the dog is already showing signs of incontinence, that leaking often gets noticeably worse after they're spayed.
Worse after spaying. That seems odd. Why would that happen?
It does sound counterintuitive at first glance, but think about it. Spaying removes the ovaries, the main source of estrogen. Estrogen is believed to help maintain the tone, the responsiveness of those muscles in the urethral sphincter.
Ah, okay. The hormones play a role.
Exactly. So if you take away that estrogen support in a dog whose urethra is already kind of structurally compromised, being short and deep in the pelvis, the underlying weakness, that USMI can really become much more obvious.
That makes sense. And what about male dogs?
Less common in males, but when it does occur, the incontinence is usually picked up after neutering. Probably similar reasons, related to hormonal changes affecting that sphincter tone.
Okay. So for a pet owner listening, what would they actually see? What are the signs of a pelvic bladder?
Well, first thing to know is sometimes it can be asymptomatic, no obvious signs at all.
Really? So the anatomy is different, but no problems.
It seems possible, yes.
Hmm.
But if there are signs, incontinence is definitely the big one, the leaking.
Just constant leaking.
It can be. It might be continuous dripping, or it could be intermittent, like, leaking when they're sleeping or relaxed.
Okay, leaking is key. But can they still pee normally otherwise, like go outside and squat?
Yes, and that's a really important point from the sources. Many of these pets still have completely normal, conscious urination. They go outside, posture, empty their bladder intentionally.
Uh-huh.
But some might also show signs of urgency, like they need to go right now, frequently, but maybe only pass small amounts each time.
And physically, what might you notice on the pet?
You might see the fur around their back end, the perineum, is stained or constantly damp from urine. Sometimes you can get skin irritation, urine scalding from being wet all the time, or just noticing the vulva or the prepuce seems perpetually wet.
Right, that paints a pretty clear picture. Okay, going back to the why, you said the anatomical position is key. Is that basically the whole story?
It seems to be the core issue highlighted in the sources, yes. Studies show a definite link. Incontinent female dogs tend to have bladder necks that are much further back, more intrapelvic, compared to dogs that aren't incontinent.
And you mentioned the shorter urethra connection again.
Exactly. Combine that deep location with the often shorter urethra, and you've got the structural setup for problems.
Can you explain that a bit more? Like, how does the location cause the leak?
Sure. Think of the bladder neck and the start of the urethra kind of like a valve. Normally, when it sits higher up in the abdomen, Changes in abdominal pressure actually help compress the urethra and keep it closed. Plus, you have a longer tube for the sphincter muscles to work with.
Okay.
But when that whole mechanism is recessed way back inside the rigid bony pelvis and the tube itself is shorter, it loses some of that natural pressure support. It makes it much harder for the sphincter muscles alone to keep things sealed tight, especially when there are pressure changes like coughing or lying down.
That valve analogy helps. Makes sense.
Hmm.
Okay, diagnostics. How do vets figure out this is the cause, especially with incontinence being so common?
Yeah, that's crucial. The first step is always a thorough workup because, like you said, lots of things cause leaking. Vets have a list of differentials they need to consider and rule out.
Like what other things?
Things like an ectopic ureter, that's where a ureter from the kidney connects somewhere abnormal, like the urethra or vagina, bypassing the bladder sphincter completely.
Okay.
Then there's just straightforward USMI, the sphincter weakness without the deep pelvic bladder complication, or behavioral issues like inappropriate urination, urge incontinence, maybe from a bladder infection or stone causing irritation,
UTI, right?
a urinary tract infection itself, definitely, and even nerve problems, neurogenic incontinence affecting bladder control. It's quite a list.
Wow, okay. How does the severity of leaking compare? Like if it's a pelvic bladder versus those others?
The sources suggest the incontinence with a pelvic bladder is often, well, worse than what you typically see with just standard USMI alone.
More severe leaking.
Generally, yes, but usually not quite as profound or constant as you might see with, say, most ectopic ureters. That tends to be very severe, often continuous leaking from birth.
Okay.
And it's also important to remember, sometimes a pelvic bladder can actually occur alongside an ectopic ureter, so you really need to investigate thoroughly.
Right. What about basic lab work? Blood tests, urine samples?
Standard blood tests, CBC, chemistry panel, usually come back normal if it's just the pelvic bladder.
Okay.
But a urinalysis is absolutely essential. It might show signs suggesting a UTI like white blood cells, bacteria, maybe blood. Or it might show very dilute urine indicating polyuria, which could point to other underlying issues.
And infection is common, you said?
Very common. So the sources strongly recommend getting a urine culture and sensitivity test. And ideally, collecting that sample via cystocentesis.
Cystocentesis? Can you remind us what that is?
Sure. It's where the vet uses a fine needle to collect urine directly from the bladder through the abdominal wall. It sounds a bit dramatic, but it's the best way to get a truly sterile sample.
Why is that so important here?
Because if there is a concurrent UTI, which happens a lot with pelvic bladder, you absolutely have to identify it and treat it properly before you can even assess the incontinence itself or plan other treatments. You need a clean sample for an accurate culture.
Got it. Treat infection first. Okay, so after ruling out infection, imaging must be critical to actually see the anatomy, right?
Oh, absolutely. Imaging is key. Regular abdominal x-rays or radiographs, they might show the bladder sitting further back than expected.
Might.
Yeah, but pinpointing the exact location of the bladder neck relative to the pelvic bones can be really difficult on plain x-rays, especially if the bladder isn't full of urine. Similarly, there is a test called an excretory urogram, or IDP. You inject contrast dye that the kidneys filter, outlining the urinary tract. It shows kidneys, ureters, bladder, urethra. But, again, often the bladder isn't distended enough to clearly judge the neck position against the pelvis.
So those aren't the best for nailing down that specific pelvic location.
Not definitively, no. For that, you really need techniques where contrast dye is put directly into the bladder and urethra.
Like what?
Things like retrograde vaginorthrography or urethrocystography. Basically, contrast is carefully injected backwards, up the urethra into the bladder. This gives a much more detailed view of the vagina, the whole urethra, its length, its shape, the prostate in males, the bladder shape, and crucially where that bladder neck sits relative to the pelvis.
Okay, that sounds more targeted. What if things are really deep down in there?
Right. If the bladder and urethra seem really recessed, a double contrast cystoarthrography can be very helpful.
Double contrast.
Yeah, you usually fill the bladder partly with air or CO2, that's the negative contrast, and then add a small amount of liquid contrast. Especially when the bladder is maximally distended, this technique really highlights the bladder wall and the urethra.
And what would that show if it is a pelvic bladder?
It often clearly demonstrates that a large part of the bladder neck, and the entire urethra are all sitting within that bony pelvic canal behind the pelvic brim. And frequently it confirms that the urethra is both short and maybe wider than normal.
Okay. What about ultrasound? Does that play a role?
Ultrasound is definitely valuable. Maybe not the primary tool for judging the exact neck position relative to bone, but it's excellent for checking for other problems at the same time. Things like hydronephrosis, kidney swelling, kidney infections, or looking for those tricky ectopic ureters we mentioned.
Makes sense. So with all these different imaging tools, is there one test or maybe a combination that's considered the best, the most definitive for diagnosis?
The sources are pretty clear on this. The preferred diagnostic approach, often called the gold standard, is combining erythrocystoscopy with that contrast imaging, the cystourethropy.
Erythrocystoscopy. What's that involve? Is that a camera?
Exactly. It uses a tiny, flexible, or rigid camera called a cystoscope. It's passed up the urethra and into the bladder.
And why is doing that plus the contrast X-rays the best combo?
Because it gives you the most complete picture. The contrast study shows the overall structure, shape, and location relative to the bones. The scope lets the vet directly look inside the urethra and bladder. They can meticulously examine the lining, check for any defects, see exactly where the ureters enter the bladder, assess the vaginal area too.
And measure things accurately.
Precisely. The combination allows for really accurate measurements of the urethral length and width, which we know are super important here. Getting all that detailed structural info is just invaluable, not just for confirming the diagnosis, but really for planning the best way to treat it.
Okay, that makes sense. Are there other tests looking at maybe how things are working, not just how they look, the function?
Yes, definitely. A good neurological exam is always part of the workup, just to make sure there isn't a nerve issue causing the incontinence. That should be normal in a straightforward pelvic bladder case.
Right.
And then there's specialized tests called urodynamics, things like systematography, which measures bladder pressure as it fills, and urethral pressure profilometry, which measures the pressure along the length of the urethra.
Urodynamics. Sounds complicated. What do those tests usually show with a pelvic bladder?
They often show that the main bladder muscle, the detrusor, contracts normally, although sometimes it might generate higher pressure at lower volumes, maybe because it's squeezed in the pelvis. But critically, these tests usually confirm what the imaging suggests: a functionally shortened urethra and often decreased pressure within that urethra. It's basically measuring and quantifying that USMI, the sphincter weakness.
Ah, okay. So imaging shows the structure. Urodynamics confirms the functional impact. Got it.
Yeah.
Okay, we've covered a lot. What it is, who gets the signs, causes, diagnosis. Now the big one.
Yeah.
What can actually be done? What are the treatments?
Right. So the absolute first step, like we stressed before, identify and treat any concurrent UTI. You just can't manage incontinence effectively if there's an underlying infection messing things up.
Makes perfect sense. Treat the infection first, then what? What are the main goals for treating the pelvic bladder itself?
There are sort of three main aims. One is to increase the resistance within the urethra, make that tube harder to leak from. Another is potentially to increase the functional length of the urethra if it's significantly short. And the third is often to surgically move the bladder neck and the start of the urethra forward into a more normal intra-abdominal position, getting it out of that deep pelvic spot.
Okay, increase resistance, increase length, or change location. How do you achieve those?
Well, to increase resistance, you might use certain medications, which we can talk about. Or surgically, you could place something like an artificial urethral sphincter or inject bulking agents into the urethral wall.
Bulking agents. Interesting.
Yeah. Increasing length is usually more complex surgery, like bladder neck reconstruction, and relocating the bladder neck surgically. That's where procedures like colpo suspension come in, anchoring the vagina to help pull the bladder neck forward, or things like urethropexy, prostatopexy in males, vas deferensopexy, basically tacking the urethra or associated structures to something further forward to provide better support.
Wow, lots of options.
The sources also mention that if the bladder seems overly active, maybe contributing to leakage, drugs to help it relax, detrusor relaxants might be considered, but usually the main issue isn't an overactive bladder muscle itself.
What about just starting with medication, like the drugs used for regular USMI? Does that work here?
That's a really good question. Medical management for standard USMI, just the sphincter weakness, is actually pretty successful in a lot of female dogs. The sources mention success rates around 75% to maybe even 90%.
That's quite high.
It is. So yes, these medications are very often tried, either as the first step or maybe alongside other treatments, because that USMI component is frequently present and often responds well to drugs.
Okay, so which Which drugs are we talking about for that USMI part?
One of the main ones is phenylpropanolamine, usually just called PPA. It's an alpha agonist. Basically, it works by stimulating receptors in the smooth muscle of the urethra, causing it to tighten up, increasing that resistance.
PPA. Okay. How's it given?
Typically, it's a pill given maybe 2 or 3 times a day. The dose is usually around 1 to 1.5 milligrams per kilogram of body weight each time, and it is often quite effective for improving continence related to USMI.
Are there downsides? Things to watch for?
Yes, absolutely. A really important one with PPA is blood pressure. It can potentially cause hypertension, high blood pressure. So, any dog starting on PPA needs regular blood pressure checks. And it's definitely something you'd avoid or use with extreme caution in dogs that already have high blood pressure or significant kidney or heart problems.
Okay, good to know. What about hormones? You mentioned estrogen earlier.
Right, estrogens are another option, mainly for what's called estrogen-responsive incontinence. Diethylstilbestrol, or DES, is one example.
DS, how does that work?
The thinking is it helps by increasing the sensitivity of the receptors in the urethral muscle to the body's own stimulating signals. Sort of boosts the sphincter's ability to contract and stay closed.
Line of the dosing.
With DES, it's usually started at a slightly higher daily dose for about a week, maybe 0.1 to 0.3 milligrams per kilogram per day. Then, crucially, you taper it down gradually to find the lowest possible dose that still controls the leaking. This might end up being once a week or maybe even less for some dogs. The goal is always the minimum effective dose.
Now, I feel like I've heard warnings about GES. Are there significant risks?
Yes, and this is a really critical point the sources emphasize. DES, although rarely, can cause serious bone marrow toxicity in both dogs and cats.
Bone marrow toxicity, what does that mean?
It can suppress the bone marrow's ability to produce blood cells, leading to potentially fatal conditions like aplastic anemia. It's rare, but because the consequence is so severe, it's a major concern.
So how do you manage that risk?
Constant vigilance. Any pet on estrogen therapy like DES absolutely needs regular blood tests specifically, complete blood counts, or CBCs to monitor their bone marrow function.
Okay, essential monitoring.
And the sources also mention that sometimes for dogs that don't respond fully to one drug, using a combination of PPA and estrogen can be more effective.
Got it. Any other estrogen options mentioned besides DES?
Yes. Estriol is another estrogen drug specifically licensed for treating hormone-responsive incontinence in spayed female dogs. The dosing is a bit different, often starting with 1 pill daily regardless of weight for a couple of weeks, and then tapering down to the lowest effective daily or maybe even less frequent dose, just another tool available.
Okay, so medical options are mainly tackling that functional sphincter weakness, the USMI part, which is often there. What about the surgery side for the actual structural problem, the deep bladder position?
Right. For the structural relocation, colposuspension is mentioned as the sort of traditional surgical approach for pelvic bladder.
Colposuspension. What does that do again?
It involves stitching the vaginal wall up to tendons near the pelvic brim. Because the bladder neck sits near the vagina, this effectively pulls the bladder neck and urethra forward, out of the deep pelvis, providing better support.
Does it work well?
The reported cure rate specifically for colposuspension in these cases is around 53%. So reasonably successful, but not guaranteed.
Is that still the main surgery done?
Well, the sources suggest that while colposuspension is traditional, another procedure, placing an artificial urethral sphincter or a hydraulic occluder cuff around the urethra, has shown success and is currently considered maybe the surgical treatment of choice if other treatments, including medical management and maybe less invasive options, haven't worked.
An artificial sphincter, like a little cuff.
Exactly. It allows for adjustable constriction of the urethra. But the sources also caution that experience with this is still somewhat limited overall, and there's a notable risk up to maybe 20% of causing a urethral stricture, a narrowing, which is a serious complication itself.
Okay, so promising but with risks. Any other surgeries mentioned?
Cystopexy is also listed as a consideration. That involves tacking the bladder itself to the inside of the abdominal wall to help pull it forward.
Right. Are there any options that are less invasive than full-on surgery? You mentioned bulking agents earlier.
Yes, exactly. Transurethral submucosal bulking agent therapy. It's considered minimally invasive.
How does that work?
Using that cystoscope, the camera, the vet, injects a substance, often collagen, is used directly into the tissue layer just underneath the lining of the urethra.
What does the injection do?
It adds bulk, plumps up the urethral walls, which effectively narrows the urethral lumen, the channel, and increases resistance to urine flow. It's often used for patients who aren't responding well enough to medication, and the success rates for improving continence are relatively good.
Does injecting that stuff actually change the bladder's position, though?
Ah, that's a key distinction the sources make. No, it doesn't. While the bulking agent can definitely help improve continence by increasing urethral resistance, it does not change the anatomical location of the bladder neck within the pelvis. It addresses the functional leaking, but not the underlying structural position.
That's a really important difference. Okay, so let's say a treatment plan is chosen meds, surgery, injection, whatever. How do you monitor these patients long term? What's the follow-up?
Good follow-up is definitely crucial. The main recommendations are 1, periodically check for urinary tract infections. Maybe doing a urinalysis or culture every 3 to 6 months because UTIs can easily recur in animals prone to incontinence.
Makes sense.
2, if the patient is on PPA, those serial blood pressure checks are essential to watch for hypertension.
Right.
And 3, if the patient is on any estrogen therapy like DES or estriol, regular CBCs are vital to monitor for any signs of those potential bone marrow problems.
Okay, ongoing monitoring is key.
Wow, that really was a thorough journey through this condition.
Yeah, we started with just defining it, this anatomical situation, bladder, neck deep in the pelvis, then looked at who gets it, mostly young female dogs, understood the signs like the leaking, but often still normal peeing too.
Right, and we explored the why, that deep position, plus the short urethra creating functional problems like USMI.
Then dug into diagnostics, ruling out other causes, the importance of finding UTIs, and how imaging like contrast studies, and especially that combo of cystoscopy and contrast x-rays, are really the gold standard for figuring it out.
Absolutely. That combination really gives the detailed anatomical picture needed to plan therapy effectively.
And finally, treatments. From medications targeting the sphincter weakness, which are often quite effective, to those minimally invasive bulking injections, and then the more involved surgical options aimed at either increasing resistance or actually relocating the bladder neck.
It really underscores how treatment isn't one size fits all. You have to consider the specific structural issues and the functional consequences for each individual pet.
Exactly. It's about tailoring the approach. So based on everything we've unpacked from these sources, here's something to think about.
Okay.
How does knowing that the bladder neck is physically located inside the bony pelvis fundamentally shift how vets approach treating incontinence in these specific animals compared to just assuming it's only sphincter weakness and prescribing a standard medication? What does this whole condition tell us more broadly about that really complex and sometimes unexpected relationship between pure anatomical structure and how the body actually functions day to day?